This video is called my local anesthetic trick for doing biopsies. And by the way, I'm great at doing biopsies. I've done thousands of them, okay? I can do biopsies in my sleep, and so I often do like the trickiest, most difficult biopsies. Here's a normal thyroid, here's some thyroid nodules, and you look at these nodules and real quick, so I'm not going to go through how to do a thyroid biopsy, all the details. I'm just going to show you a trick for doing difficult cases in the thyroid, or it doesn't have to be thyroid, it could be anywhere. I'm just showing you some tricks on how I do the really difficult cases. First of all, you have to make a judgment, which is easy, which is difficult. So this nodule in the lower pole of the left thyroid would be a walk in the park because it's so big. This nodule is much smaller, so it's harder to hit. And you know, there's other variables. A nodule up high in the thyroid is going to be easier because you're far away from the lung. Okay? Down here, it's a little dangerous. You're next to the lung. You're often closer to the carotid, and that, you know, lower thyroid pole, posterior, that can be a tough spot to get to. I'll show you, you know, and that's what this is about, is how does one deal with it. So in this example, the thyroid nodule will be the black circle here. Here's the trachea. You can't go through the trachea because then air will leak into the field and you're screwed. You can't go through the jugular vein. You don't want to do that. You got to be careful when you're coming in here. You don't hit the carotid. Okay, so those are typical questions, and I'm going to show you how to work around all this stuff. Okay, and I'm also going to show you, doing a tiny little nodule in the lower pole of the thyroid, next to the lung, next to the carotid, blocked by the jugular vein on one side, blocked by the trachea on the other side. That's the thyroid biopsy equivalent of Evel Knievel jumping Snake River Canyon. When I was a young guy, men were men, we had hair on our chest, okay? We didn't go around like the modern metrosexuals wearing bracelets and, looking like women, okay? And this was Evel Knievel, the motorcycle daredevil jumper, when he was getting ready to jump Snake River Canyon, okay? I remember this stuff when I was growing up. We used to jump our bicycles over stuff. It was kind of crazy, but that was the macho mentality of America back in the day when America was a great country and a heroic country, rather than sort of this modern, pussified country that it's becoming. Okay. So here's Evel Knievel, showing everybody what he's planning to do to jump over Snake River Canyon. All right, so now let's get back to the biopsy. Another pitfall is you're dealing with the clavicle. The clavicle is not a straight structure like they draw it in anatomy textbooks. In the real people, it's very much a diagonal structure. And so what that means is you can't, your transducer wants to be parallel to the clavicle. You can't move the clavicle out of the way. You can try getting a smaller transducer, but it's awkward. The clavicle is an obstacle to doing a lot of these lower pole biopsies, okay? I've done over 1,000 of them. I don't even know. I've probably done about over 2,000 of them. I've done so many ultrasound guided procedures, not even funny. I've done about 3,500 PICC lines. I've done well over 1,000, probably about 2,000. I don't know how many dialysis catheters, just tons and tons of them. I used to do multiple cases every day of these procedures. All right, so I'm going to also show you some of the other little pitfalls here. So you got to deal with that clavicle. All right, so now here's the big trick. Here's the moment you've been waiting for. If I'm asked to hit this nodule, when you first look at it, anybody who understands biopsy, it's technically impossible. I can't go through the trachea. I got to come from way over here from the skin. This is the skin edge, the edge of the field of view here. I have to come from here, and how am I going to get in this nodule? The trachea is blocking my path to it. I can't get it from there. I can come from this side, but I'm screwed with the jugular vein. This is big blue, the internal jugular vein. And here's big red, the common carotid artery. So how am I going to do it? Okay, so now I'm going to show you my trick. My trick is I'll just unload a full syringe of local anesthetic right here, and I'm going to create a larger field of view so that I can get an angle where I can now come like this. Okay, I have to artificially inflate this segment so that I can create an angle where I can get around this trachea. So I can't get it from here, but if I puff up this near field a lot, I can create an angle where I can hit it. All right. The other thing is I can soak the subcutaneous tissues in front of the jugular vein and then smush the jugular vein down and push it down out of the way, and then I can hit it like that. And I often do all sorts of tricks. I'll have to do a core biopsy, and the far field is too dangerous because there's a carotid artery or some other dangerous structure there, some big nerve or something. So I'll pump up the near field with local anesthetic. So then, and I can take a short step off slot on my core needle, and I'll be able to get the thing. So These are really advanced cervical biopsies. I've done so many biopsies I laughed at. If it's a routine case, I don't even need to look at the films. I just tell the tech, I'm like an old prostitute. I'll just do whatever's on the schedule. If it's been approved, that means I could do it. I don't need to look at it again if somebody else has already approved it. And so what I'm just trying to tell you, trust me, I've done many thousands of these. The local anesthetic trick enables you to do a lot more cases that you otherwise couldn't do if you want to try to do those cases. They're a little tricky, but that's the trick, and it's a great trick, and it works.